everyone. Good evening, sir. Today my case is a 25-year-old female patient who has come with progressive swelling in front of neck with symptoms of anxiety, sweating, weight loss, and tremors in her hand. This was the case scenario given to me, sir.
Okay.
Going to the history of the patient, she is a 25-year-old female. I'll ask about what occupation, her residence, and from where she is hailing, and from how long she has been having this swelling. That is her chief complaints. Whether the swelling has been increasing in size, whether it is sudden or it is over a longer period of time. Then I'll also ask her the which side did she notice the swelling, whether it is any side specific, and then it increased wholly or not. Then I'll ask her about other symptoms, like whether the swelling moves with deglutition or not, whether she has any dyspnea or lying down, whether it is whether the dyspnea is getting relieved on any position, whether she prefers sleeping in one position, does she have any stridor, any uh, difficulty in taking solid and liquid foods, and whether she has any uh, history the already positive history given is that she has anxiety, sweating, weight loss, and tremor in hands. I would also like to know whether she has any menstrual abnormalities, any double vision, any skin lesions present or not, whether she has any palpitations. Then I'll also like to ask whether she has any cold intolerance, any hair loss, any depression, any altered sleep pattern, any swelling of the limbs, any dryness of the skin. uh, I would also like to ask whether she has any history of recurrent fever, any history of recurrent upper respiratory tract infection, any history of hemoptysis, any history of abdominal pain, any history of hyperpigmentation, jaundice. Then I would also like to ask any history of syncope in the patient. Then I would like to know about her effort tolerance. Then coming to the past history, I would like to know whether she has any comorbid conditions like diabetic hypertension, COPD, bronchial asthma, CVA, or any malignancy in the past, or seizures in the past. Any history of previous hospitalization or any operative interventions has been done or not. Any history of any drug allergy, or is she taking any allergic medication, any drugs regularly? I would like to know. Then coming to, also like to ask family history or regarding the same any swelling and has been operated previously for that or not. I'll also like to elaborate on her menstrual history. Then I would like to ask about whether she's married or not, and her obstetric history. I'll also like to know if she's married and she has a child, if during the obstetric history also whether she had any of these symptoms, I would like to know. Then coming to personal history, I would like to know about her appetite, her bowel and bladder habits, any substance abuse, her sleep pattern, and whether it is disturbed or whether she prefers to sleep in any specific position. Uh, then after my history, I would like to summarize this case, saying that I have a 28-year-old female patient with the progressive swelling in front of neck, with associated symptoms like anxiety, sweating, weight loss, tremor in hand. Other uh, positive findings may be that this swelling might be moving with the deglutition. Coming to, then I will go to the general examination.
One
Uh,
second, one second. Now, this history, did she consult anyone? Did she get any treatment for this? Did you ask about that? Because the gradually increasing swelling in the neck and the
yes, sir.
patient becoming anxious, having tremors. Did you
Yes, sir.
ask about any treatment history? You said she has not been taking any drug on a long-term basis, allergy and other things. But
Yes.
any treatment tried for this?
So I asked whether she had any previous hospitalization or any operative interventions has been done for the swelling or not in
No,
her
no,
past
no.
histories?
Nobody will hospitalize a patient for thyroid swelling and its activities, isn't it?
Yes, sir.
So we must always ask whether did she consult anybody, any doctor for this problem, and
Yes.
was she put on any medication? Because
Okay.
if supposing just before seeing you, she has started the drug only 2 days ago. She
Mm.
has consulted somebody and somebody has diagnosed hyperthyroidism and started her on medication.
Yes, sir.
Right. That is the possibility of that.
Yes, sir. It can be.
Uh, how long it will take to control the symptoms once you start the treatment?
It will take around 4 to 6 weeks for the symptoms.
Ah,
Uh,
so the patient might have just seen the doctor 2 or 3 days ago and still may
yes.
be having all the symptoms.
Yes,
So
sir.
if you miss that, she may be already be on some treatment, isn't
Some
it?
treat.
So
Okay.
always don't forget to ask about the
Yes.
treatment for the complaint. Okay,
Okay.
not for the comorbidities alone, for the specific complaint, whether they had taken any treatment, that history also should be always elicited.
Yes, sir.
If she has not taken, you can always mention the first time she is coming to the hospital, she has not had any treatment for the present complaint. That can
Okay.
be the documentation. Okay, go ahead.
Yes. Yes. Coming to examination, uh,
Hmm.
I will examine whether the patient is conscious, cooperative for my examination, and whether she is oriented to time, place, person. How is her build and nourishment? I will
Hmm.
take her height, weight, and I will calculate her BMI. I will look for
Hmm.
any pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema present or not. Coming to the vital signs, I'll check her temperature, her
Hmm.
pulse rate, whether it's regular in rhythm, normal in
Hmm.
volume and character. Her BP will be measured in the right arm in sitting position, and then her respiratory rate and how it is, whether thoraco-abdominal in type or not. Then SpO2 and Romal will be measured in sitting position. Coming
Hmm.
to specific examination of the uh, front of neck on probably thyroid swelling, I suspect. So I will
Hmm.
inspect her from in sitting position from front and from I'll examine her from sitting in front and lateral and from behind the patient. Coming to
Hmm.
inspection, uh, with adequate exposure, patient is asked to be sitting in position with the head thrusted backwards against the hands, clasped
Hmm.
behind the occiput. See whether the swelling, whether the anterior uh, and see how the size is and whether I could
Hmm.
see the lower border of the swelling will be noted, and whether the suprasternal notch is visible or not will be noted, and the skin over the swelling, whether any ulcerations, sinuses, scars, edema, dilated veins present or not will be noted. Then I will also ask her to drink a glass of water a little bit, or I will ask her to swallow her own saliva to see whether the swelling moves with the deglutition or not. And I'll also ask her to protrude the tongue, whether to see it moves with protrusion of tongue or not. I will also see in inspection whether there is any prominent veins over her neck and anterior chest wall is present or not. I will also see for any hand tremors and tongue tremors present or not. She also gave a history of tremors. Probably, if it is a thyroid swelling, then it will be a fine tremor, which will be which we can make it apparent by putting a paper on our outstretched hand to see the
Hmm.
tremors.
Okay.
Coming to palpation, uh, the will be examined from behind and from lateral position. I will see the size of the swelling and measure it. I will see the lower border of the swelling, whether it is palpable or not. Any local rise in temperature, tenderness over the swelling is present or not. How the surface of the swelling is, and how the consistency of the swelling is. Whether the overlying skin is fixed or not. I will see for tracheal palpation, and whether it is displaced to left to right, I will check it, and I will see whether the carotid pulsation is felt or not. uh, then coming to percussion, I will see whether there is any resonant note present over the manubrium sternum or not. Then auscultation, I will see whether there is any bluey over the swelling. Uh, then eye signs which can be elicited in this patient are Van Graff's sign, Dahl-Rumpf's sign, Joffrey's sign, Stellwach's sign, and Moebius sign. I'll see whether these signs are present or not. Coming to systemic examination, respiratory system, I'll auscultate her, see if there is any added sounds. I will check bilateral air entry and I'll check the use of accessory muscles. Cardiorespiratory system, S1, S2 heard and any murmurs present or not. Central nervous system, patient's consciousness, orientation, motor system examination, power of all the five limbs will be checked, tone of the muscles will be checked, and sensory system will be evaluated, and uh, deep tendon reflexes should be evaluated. Per abdomen, whether it is soft and whether it is non-tender, and bowel sounds should be evaluated. Coming to airway examination, any facial dysmorphic features present, see the bilateral nasal passage patency, the interincisor gaps, sternomental distance, thyromental distance, then upper lip bright test, and then Malampati grade, then submandibular space, whether it is soft or not, any retrognathia, see for the temporomandibular joint, I'll see the tongue, the neck movements, neck circumference, and dentition will be checked. Coming to the provisional diagnosis, I have a 28-year-old female patient with the front of neck swelling, with this progressive in nature, uh, with the signs of suggestive of hyperthyroidism, with no other comorbid conditions present.
Now there are a few things I would like to know.
Yes, sir.
How will you know whether you said you will ask, tap over the suprasternal manubrium sterni to find out the resonance?
Yes, sir.
Okay. Does it conclude? Why do you want to do that?
To see whether there is any retrosternal extension of
Retrosternal extension. Will it be always positive?
only
Which
if
will be a
the
better test to do?
sir.
Which will be a better test to rule out retrosternal extension?
So to get below the swelling, if and Pemberton sign can be done.
Pemberton sign. Yeah, you must always mention Pemberton. You said so many things about the eye signs.
Yes.
Never, even if it is negative, don't forget to mention Pemberton sign also. Okay.
Okay.
So
Yes.
Pemberton sign is a very, very important test which have to be done
Yes, sir.
to rule out a compressive retrosternal goiter. Okay.
Yes,
So
sir.
please, even if it is negative, please mention that. Then coming to the airway examination, you said thyromental distance. With a large swelling like this, will the thyromental distance you measure will be normal?
No, sir. We cannot measure the thyromestal distance properly.
Then you said this is a normal. That is not correct, isn't it?
Yes.
So the thyromental distance is not valuable in
Yes.
assessing the airway in these patients. Okay,
Yes, sir.
so that is another thing that you have to be very watchful. And the
Okay.
third important thing is when you inspect and palpate the swelling, you must know whether it is arising only from the right lobe or left lobe or both the lobes.
Yes, sir.
Isn't it? That is a very important finding that you have to give. Whether it's a bilateral swelling or a unilateral swelling. Okay.
Okay. Mm.
Now, from this position and examination, what is the normal level or the anatomical level of your thyroid gland in an adult?
See,
Where is it situated?
it is situated from a level of C5 to T1 vertebral column, sir, and
Hmm.
the lobes are present from middle of the thyroid cartilage to the fifth tracheal ring.
Tracheal ring anteriorly. Okay. So vertebral size wise, you have to say C5 to T1, but anteriorly it is from the middle of the thyroid cartilage to C5 ring. And whereas the isthmus,
Isthmus, it is present from C2 to C4
C2,
tracheal.
C3, C4,
So
correct.
tracheal ring.
tracheal rings. It is placed over the C2, C3, C4 tracheal rings. Okay, right. What is the embryology of thyroid gland? Where does it arise from? When does it start in the embryological age and in the gestational period? And at what gestational period it reaches the normal height?
Sir, from the third week of gestation, it starts developing from the first
Mm,
and second pharyngeal arches, sir, which is an
mm,
endodermal thickening, and
mm,
it descends down to the normal location,
mm,
and it divides to form the isthmus, sir. Uh,
mm.
then around the uh, fifth, 10th week of gestation, it will be present in the normal.
Seventh week, if by seventh week of gestation itself, it reaches its normal position. Okay.
Yes.
Where all can it get arrested during its descent from the pharynx to the neck?
It can it normally starts in the foramen cecum,
Mm,
uh, so it can get present there, or it can be present in the near the hyoid bone,
mm.
or it can be present
Suprahyoid, infrahyoid,
in hyoid
okay,
locations.
like that.
Can be.
So you can start saying at the lingular level, suprahyoid level, infrahyoid level, or a thyroid cartilage
Yes.
uh, level. Okay. So why do you want to do the moving with deglutition test? What is the mechanism?
Sir, because thyroid gland is covered by pretracheal fascia, a thickening
Mm.
of pretracheal fascia on the backside is the Berry's ligament, which is attached to the thyroid cartilage, sir.
It moves with deglutition. So
So,
how do you differentiate between a thyroid swelling and a thyroglossal cyst?
sir, thyroid swelling only moves with deglutition, but not with protrusion of tongue. But
Mm.
the thyroglossal cyst also moves with protrusion of tongue, sir.
Okay. Supposing this patient has a fracture, this patient now with all the clinical symptoms described in the case scenario, she
Yes, sir.
has a fracture forearm and they want to do a plating. How are you going to manage this case?
Sir, first I will have to evaluate her thyroid status
Very
uh,
good.
by doing by seeing her clinically and by doing certain investigations.
Hmm. What
Uh,
investigations you want to do and what results you expect?
Sir, I would like to do her normal routine investigations like CBC,
Hmm. Hmm.
RFT, serum electrolytes, and all those things.
Okay.
And I will also like
Okay.
to do specific investigations like uh, a thyroid function test, which
Hmm.
has TSH, T3, and T4 levels.
Hmm.
I expect, since she has hyperthyroid symptoms, I expect her TSH to be low and her T3, T4 levels to be higher, sir. If it is because of the, uh, if it is a primary hyperthyroidism, then her
Ah,
TSH levels will be low, sir.
low. Hmm. Okay. So if this fracture forearm an emergency, they want to do they say it's a compartment syndrome, there's a swelling, so we want to operate as early as possible.
Okay, sir.
And you have diagnosed hyperthyroidism. How
Yes,
are
sir.
you going to manage this case? He has not taken any treatment so far.
Yes, sir. First,
Hmm.
I have to. It is if it, even if it is an emergency, we can since it is a limb loosening surgery, we have to optimize her and take her up immediately. For optimization, we can give first have to give antithyroid drugs to act the already present thyroid hormones and to prevent the further release. And we have to do rate control by giving beta blockers. Antithyroid drugs which can be given are propylthiouracil or methimazole can be given. After giving these drugs, we can also give um uh, Lugol's iodine.
Hmm.
Then we should give beta blockers to control the rate of the patient and to decrease the sympathetic response. like propranolol can be given, or esmolol can be given. Then we can give steroids like hydrocortisone, 100 to 200 mg can be given. Um then we have to give
Now, all these things, are they going to control the hyperthyroid state immediately and give you a new thyroid patient for surgery?
no sir, it will control further release and prevent patient landing up in thyroid storm.
Ah, that is the answer that you have to give. This patient is at present not a suitable candidate for surgery because there is a high risk of thyrotoxic crisis happening because of the strain,
Yes
stress,
sir.
isn't it?
Yes
So
sir.
if you have told that answer, that will be the better answer rather than trying to say, I will give that drug. Because then the examiner will ask you why you say that, because it will take at least 4 weeks for the control of the symptoms, isn't
Yes.
it? The
Yes.
making the patient euthyroid.
Yes sir.
So if you say that answer, that will be a better accepted answer rather than trying to say, I will give all the treatment. Okay?
Okay.
So
Okay sir.
don't be frightened to say that answer, because a patient with an uncontrolled hyperthyroidism is a more riskier patient than a patient who is euthyroid. And
Yes.
if the surgery is not life threatening, then it can always wait. Okay, so
Yes.
you should be bold enough to say that in the examination so that examiner will appreciate your care and your
Yes.
concern about the patient.
Yes
Okay,
sir.
so you have to be, don't worry to say that I will, and you say if at all the surgeon insists saying that the limb is ischemic, so I have to explore and do something like that. If they coerce and pressurize you, then you can
Yes.
always say, I will be I'll make all arrangements to manage a thyroid crisis and keep everything ready, like ICU backup,
Yes sir.
keeping senior help, and keeping all the cooling drugs and the cooling agents and other
Yes.
materials that are required to manage the thyroid storm. I will keep ready and then go ahead with the case. If at all
Mm.
there is a compulsion to do this case. Okay.
Okay. Okay
So,
sir.
so that is the answer that you can give in an uncontrolled hyperthyroid patient coming for surgery.
Okay. Yes sir.
Now, the common questions they may ask you is, what is the function of thyroid gland? Why it is very important for us?
Sir, thyroid hormones, they are required for vital function of the entire organ system for the from neonatal from the fetal stage. It is required for growth, development, and for skeletal maturation. It is important for calorigenesis, and it is important for thermal regulation also. In calorigenesis, it is important for carbohydrate metabolism like gluconeogenesis, genolysis, and it also helps increases the insulin mediated glucose uptake, promotes the beta oxidation of fatty acids, and
Okay. What is basal metabolic rate? How do you define BMR?
so, BMR is the uh, weight in kgs divided by height in meters square.
It is BMI. You are saying BMI. I'm asking BMR, basal metabolic rate. How do you define basal metabolic? You are telling about BMI, height in centimeters divided by weight in kilograms.
Yes sir.
What
minimum
is the
amount of
definition of?
energy
Huh?
required to make minimum amount of energy required to maintain complete physical and mental rest in the post-absorptive states.
Post-top state. It is the amount of heat produced by consumption of a normal diet. Okay? It is the amount of basal metabolic rate is the heat produced by consumption of a normal diet under standard conditions. What are the standard conditions? The patient should be a relaxed patient and he should have had his food at least 12 hours before.
Hmm.
These two things are maintained, then it is the amount of heat energy produced by his assimilation of the food is called the basal metabolic rate, and it is about 192 kilojoules per hour or 40 calories per hour. Okay, that
Yes,
is the value. It is calories per hour is the value for PMR. Okay,
yes, sir.
and what is the synthesis? How is the synthesis of these hormones done?
Sir, from it is synthesized in the thyroid gland by taking the dietary iodine. The thyroid follicles take up the dietary iodide by sodium iodine symporter, and then the iodine is oxidized. Oxidation and organification of the iodine molecules occur with the tyrosine amino acids, by enzymes like thyroid peroxidase and iodinase enzymes, sir. So it forms monoiodothyronine and diiodotyrosine, sir. So these two molecules again coupling occurs by thyroid peroxidase to form T3 and T4, sir. These are stored in the thyroid follicles and released, sir. And later they are released.
How is the release achieved? They are synthesized in this way and stored by endocytosis in the thyroid follicular cells.
Yes, sir.
What is the mechanism of their release? Will they be constantly released or will they be released on demand?
They constantly some amount will be released, sir.
Like insulin? Is there a basal level with which it is released? What is the role of thyroid stimulating hormone? TSH. What does it do?
It causes release of thyroid hormones, sir.
So the thyroid stimulating hormone is the controlling thing. Okay,
Yes,
it
sir.
comes and gets attached to the thyroid receptors on the follicular cells, and then what type of receptor is that? TSH receptor.
G protein coupled receptors.
G protein, very good. G protein coupled receptor. So through mechanical cyclic AMP will be increased and protein kinase A will be increased, and that will stimulate the release of endocytosed thyroid hormone. Okay,
Yes, sir.
so the trigger for release is thyroid stimulating hormone. Okay,
Yes, sir.
so that is how it is released and it is utilized in the body. What is the quantity of T4 released per day and what is the quantity of T3 released? Which is more?
Sir, more is T4, sir. 80% will be T4 and 20% will be T3, sir.
T3. So what is the method of the action? Is T4 active or T3 more active?
T3 is more active, sir. There will be peripheral conversion of T4 by deiodinase enzymes.
What is reverse T3?
So reverse T3 is an inactive form of T3, sir.
T4. T4 converted, part of it is converted to active T3 and part is converted to reverse
Reverse
T3.
T3.
It's an inactive form. So what is the structure of the T4 hormone? What does it contain structurally?
It contains two diiodotyrone.
Benzene rings. Okay, it is just
Yes.
a combination of two benzene rings with an oxygen molecule with four sides for iodine attachment. Okay,
Yes.
there is an inner ring and an outer ring. Benzene rings are divided into inner ring and outer ring, and each ring has got two iodine in the third position and fifth position of the benzene ring. So the
Yes.
inner ring is called 3' and 5'. The outer ring is called 3 and 5. Okay.
Yes.
So the removal of one of the iodine makes the T4 to become T3. So whether it is going to become active form or to reverse T3 depends upon the removal of whether it is a primed iodine or a non-prime iodine that is being removed. The main mechanism by which it is released, made active. Okay.
Yes, sir.
Right. So this is the synthesis and release. All these the basic physiology question you should be able to understand. Now, if
Yes.
this patient requires treatment for her hyperthyroid state, what are the drugs that you are going to prescribe?
Sir, methimazole, carbimazole, or propyl thiouracil can be prescribed, sir.
No, this patient comes to you, she is a relative of yours, she comes to you for treatment. What drugs you will prescribe and what dosage you will give. Tell me the prescription that you will provide her.
Sir, I'll give around 200 to 400 mg of oral propyl thiouracil, sir.
Is propyl thiouracil commonly prescribed nowadays? Have you
Carbimazole
ever
is
seen an endocrinologist prescribing propyl thiouracil to patients nowadays? It's
methimazole.
almost become obsolete because it is causing lot of side effects. What are the side effects of propyl thiouracil which make it an unfavorable drug?
Sir, it causes agranulocytosis.
Blood risk. Okay, very, very important and a very common complication. The patient
Yes.
will become have low platelet, it will become anemic, their neutrophil count will go down. Okay, so the most endocrinologists have stopped prescribing propyl thiouracil nowadays. So the drug of choice is neomercazole. Okay,
New.
so that is
Yes,
the
sir.
drug that is given. Along with that, what is the other drug you can prescribe?
Sir, potassium iodide.
Propranolol. Okay, so the common treatment that you have to prescribe is neomercazole and propranolol, the patriac beta blocker. Why you prefer propranolol rather than a cardioselective beta blocker?
Sir, it also acts and also decreases the peripheral conversion of T3 to
Apart from the
T4.
cardiovascular effects, propranolol alone has got this effect. If you
Yes.
prescribe a cardioselective like metoprolol or bisoprolol, it will act only on the cardiovascular system. It doesn't prevent the peripheral conversion of T4 to T3. So propranolol is the ideal drug for also helping to control the hyperthyroid state better. Okay? So this is what you have to prescribe and the patient has to be treated and you will see the results in 4 to 6 weeks the patient. So you have to repeat the thyroid function test to find out whether she has become euthyroid or not. What are the indications for removing the thyroid? Thyroidectomy. What are the indications for thyroidectomy surgery?
Well, if they are resistant to medical management,
Failed medical management. Okay, that's a resistant or failed medical management. Then
cosmetic reasons can also be an indication for removal of thyroid gland. And malignancy of the thyroid is also an indication for removal.
very good. Excessive growth and compression effects. Okay,
Yes, sir.
the thyroid becoming bigger and bigger. Even if the patient is euthyroid, but the gland goes on increasing in size and starts producing compression of the trachea, esophagus, swallowing difficulty, breathing difficulty. All these things are indications for thyroid surgery. Supposing this patient unfortunately needs a thyroidectomy, a total thyroidectomy, because she has not responded to medical management.
Yes.
How are you going to anesthetize this patient?
So first, I will also do some investigations to see how the swelling is. I will take a,
No,
X-ray of the neck.
be precise and short. What is the main concern? The case, if supposing this gland is very huge
Yes, sir.
and causing compression effects, and you need to remove that because of that. What is your main concern?
So I want to see how much it is compressing the trachea.
Airway. One word answer for this is I am worried about the airway. Okay, so it may be a airway compression at the tracheal level or a lower down. Okay,
Yes, sir.
so what is the investigation pre-op investigation you would like to do?
Sir,
Assess the
X-ray of
degree of
the neck. X-ray of the neck, AP lateral.
Very good.
If it shows more than 50% of tracheal compression, I would like to do a CT neck and chest
Okay.
also. Then I would also like to do a video laryngoscopy to see the vocal cord movements and to document the vocal cord movements. Then I would
The
like to
compression
do,
is below the vocal cord.
sir.
The compression is below the vocal cord, not at the vocal cord level,
Yes, sir.
because of the huge thyroid. So what other airway
Fiber
examination?
optic.
Fiber optic, yeah, it's a very important thing that you must exactly locate where exactly the compression is happening in the trachea. Okay, so a fiber optic bronchoscopic examination is also very, very important.
Yes,
But
sir.
what is the non-invasive method by which you can find out this compression and the narrowing?
Airway ultrasound.
Airway
Ultra.
ultrasound, excellent. So you can do a airway ultrasound nowadays, which is gaining more popularity because of the non-invasive nature. So you can assess the size of the tongue, you can assess the
Yes.
pharyngeal area, you can assess the glottic opening, you can assess the narrowing or the normal diameter of the trachea. Everything can be made out by a non-invasive ultrasound also. Please remember that that is being repeatedly insisted
Yes.
nowadays because these are all modalities which are now coming more and more in practical use. So always remember the usage of ultrasound for assessing the airway apart from the routine clinical and earlier methods of fiber optic scopy and other things. Okay.
Yes.
Right. Supposing this patient is posted for total thyroidectomy,
Yes,
and
sir.
of course, by some drugs, she has become euthyroid because of the pressure effect. They want to do a thyroidectomy.
Yes, sir.
Tell me how you anesthetize this patient.
So first, preoperatively, I would like
All the
to count.
investigations, everything is done. She has been given fitness. So she is on the table. You want to proceed with the surgery. She had hyperthyroidism, well controlled. She is taking neomercazole 5 milligram 4 times a day, and she is
Yes.
on propranolol 20 milligram BD. All that has controlled her hyperthyroid state. She is now euthyroid both clinically and biochemically, and she
Yes, sir.
needs a thyroidectomy, total thyroidectomy.
Okay, sir.
Tell
Sir,
me.
I will give her a preoperatively anti-aspiration prophylaxis. I will avoid any sedative pre-medications preoperatively. Then I will get an informed consent and also consent for uh, uh, any post-operative mechanical ventilation might be needed, and I will also counsel her regarding the need for tracheostomy since it is a huge
Okay,
thyroid swelling with
very good.
compression,
Okay.
and I will
What
give
about the
her
anti-thyroid drugs? What is the instruction that you want to give regarding anti-thyroid drugs?
anti-thyroid drugs should be continued on the day
Continued.
of surgery.
That is the for most important instruction. That is the first thing you should say. I will ask her to continue the anti-thyroid medications on the day of surgery with sips of water. That is the
Yes,
first
sir.
instruction. All the other things are routine, right? Okay, patient has been brought to the OT.
Yes, sir.
Oh,
Sir, I will my plan of anesthesia for this patient will be an awake fiber optic intubation followed by uh, muscle
supposing she has
relaxation.
a Malambati score of 2,
Yes, sir.
and neck mobility movement is quite okay, mouth opening is adequate. Still, do you want to do an awake fiber optic intubation?
So we can also do an inhalational induction with spontaneous breathing patient, but I don't want to do a IV induction for this patient, sir, because of
Why?
the
Why you don't want to do an IV injection?
because since it is a huge thyroid swelling, if I give IV muscle relaxation or induction agents, the thyroid swelling may compress the trachea. The weight of the thyroid swelling may compress the trachea. So then it will be
So,
difficult
is
to
there
ventilate.
no way that you can get this compression out?
So you can ask assistant to hold the thyroid swelling
Yeah,
away.
yeah, you can do that and go ahead and do an intravenous injection, which is much more comfortable to the patient than inhalation injection, isn't it? So, unless you have a documented evidence of narrowing of the trachea because of the huge size, your answer is right. Okay. So, the answer
Okay.
why you should prefer awake fiber optic intubation is if you find a definitive narrowing both in the AP and lateral views of the trachea because of the size of the gland. It is always safer to do an awake fiber optic intubation and pass the endotracheal tube beyond the narrowing. That is the advantage of using the awake fiber optic. Okay? Because otherwise, what will happen? There is a chance that that area may collapse once the gland is removed. Whereas if you do a fiber optic intubation, you can always see that narrowing and push your tube beyond that narrowing to the normal distended distal portion. Okay, so that is the reason why you have to think of awake fiber optic. Otherwise, if there is not much of narrowing made out both by the X-ray as well as the ultrasound, then you can go for a regular induction, but always keep an assistant, as you said, to take the weight of the gland by pulling the gland forward if it is going to cause a compression on the trachea. Okay, that is the answer that we have to give. What about the IV line? Starting from the IV line.
So IV line, I
Where
will
will you
take.
start an IV line? That is the first and foremost problem in all thyroid cases. Where to site the IV access?
In the dorsum of the hand.
With the extension, always never say dorsum of the hand alone. You should have a IV access. You can choose as regular as you do regularly with the dorsum of the hand, but always have a 50 or 100 centimeter extension line to have a good access to the IV line that you have put in. Otherwise, the alternate will be to
We can put in
the line on the leg, okay, dorsum of the leg or the ankle. That will be another choice. If you don't have an extension tubing available, then you can go for a IV access in the dorsum of the foot or the ankle of the patient.
Yes.
So that you can easily approach that IV access without disturbing the surgeon and his assistants, who will be surrounding and standing near the patient, and the hands will be abducted and kept close to the patient, unlike other surgeries where it will be
close to the
spread out.
patient.
Okay. Which tube you want to use for intubation?
So I want to use a flexometallic tube or a armored tube.
Same, both are same. Flexometallic, armored, both is the same tube with names are different. Okay.
Yes.
Any other option other than flexometallic?
We can also use the North Pole tube, sir.
Pole tube in the oral route. Okay, not in the regular. North Pole is meant for nasal intubation, but you can use the same North Pole or the nasal ray tube orally. This is one indication for using the North Pole tube in the oral route, and so that the bend will come away from that. Now, what are all the precautions you should take when you position the patient for thyroid surgery?
Sir, we should give. We should put iPads and
Prevent the
we should
pressure
cover
in the
the
eye.
eyes.
The answer is prevent the pressure in the eye. Avoid too much of extension of the neck. Even the surgeon will ask for good extension of the neck. But what is the danger in giving too much of an extension?
So there can be compression of the neck vessels and
neck veins. The drainage of the neck veins will be affected by stretching because the veins will collapse, and that will cause pharyngeal and facial edema. Okay?
yes,
So avoid too much of extension and stretching of the neck, and then make sure that all the pressure points are taken care of by adequate padding. Okay? And placement of the ECG leads well away from the operative field in the lower part of the chest and back if necessary will be ideal, so that you will get a continuous good display of ECG also. Okay, and the pressure cuff can be tied in the hand, the upper limb, but the line should be, monitor will be ideally placed where for thyroid surgery?
In the foot end of the surgery.
Towards the foot end of the patient. That will be better to keep it there and make sure that the breathing circuit is not very heavy and dragging on the tube. It should be a lightweight disposable tubing so that it will not drag on the tube, and plaster fixation for the tube is very essential, and mark the centimeters
Yes,
the
sir.
tube has been inserted so that you can assess whether it is will it come out when the position is made by extension, or it will go in.
It will come out, sir.
It will have a tendency to slip out. So always mark the length that has been introduced so that you can find out whether any dislodgement has taken place or not. What are the early indications of development of a thyrotoxic crisis or a thyroid storm intraoperatively?
So there can be increase in ETCO2. There
Hmm.
can be increase in temperature,
Hmm.
and there can be increase in heart rate, sir.
Heart rate. So early increase in CO2, tachycardia, temperature. These are the three things that we have to suspect that it is a thyroid storm. How do you manage a thyroid crisis?
So first we should stop all the stop the surgery or the stimulus.
Inform the surgeon and stop the surgery. That is first answer. Okay.
Then 100% oxygen.
Hmm.
Then through the Riles tube, we can give antithyroid drugs.
Hmm.
Then we can give IV propranolol or
Hmm.
esmolol can be given.
Hmm.
If there is then if there is hypotension, it can be managed with the phenylephrine. Then we should also give a cold saline infusion, and we should do active cooling of the patient.
Very good.
If
Apart from the esmolol, any other drug can be given parenterally?
IV, sir, hydrocortisone can be given.
Hydrocortisone also.
100
Through
to
the Riles tube, apart from any antithyroid drugs, any other drug which
we
can
can
be
give
given?
Lugol's iodine, sir.
Leukocytin also. So all these things, all of you know that these are the things that are commonly asked.
Yes,
And
sir.
what are the post-op complications of these cases, thyroidectomy cases?
Immediate complications can be like recurrent laryngeal nerve palsy or laryngospasm can occur, or laryngeal edema can occur.
Spasm and laryngeal edema.
Edema, sir. Then
So how can you detect laryngeal edema?
by doing a cuff leak test, we can do.
Very good. Excellent.
Yes.
You have to do the cuff leak test before you remove the tube. Very, very
Yes.
important. Tracheomalacia is another common complication which may require re-intubation later if necessary. What are the late complications? Delayed complications.
Delayed complications like
Intermediate.
can be hypocalcemia can occur, which can also cause
It is
laryngospasm.
very late. Any intermediate between the acute on the table to the late complication of hypocalcemia?
There can be hemorrhage in that area. Hematoma formation
Hematoma.
can be there, sir. That can
What
also
is
cause
the recent
compression.
guidelines on post-thyroid hematoma complication? Are you aware of any recent guidelines by the Difficult Airway Society of British Difficult Airway Society and Thoracic Society and ENT guidelines on post-thyroid hematoma management?
There should be a suture removal beside the patient, and alternate sutures should be removed. The patient should be intubated
Have
and
you heard of
taken.
the acronym SCOOP? SCOOP, SCOOP, for management of hematoma, post-thyroid surgery hematoma?
No, sir.
No. That is brought out by the British Society and the ENT Society
Yes,
in
sir.
2021. Difficult Airway Society, they have formulated a guideline what to do. These patients should be observed. They will be usually, what will be the complaints if the patient develops hematoma post-thyroidectomy?
There can be breathing difficulty can be there.
Will it always start immediately with breathing difficulty or something else first? First, they will develop swallowing difficulty, then breathing difficulty, then stridor,
Yes.
okay, then hypoxemia and breathlessness because of hypoxemia. All these things will settle it. Okay, so
Yes.
there are early warning signs and new early warning signs. They call it as EWS and NEWS. So there should be constant observation of all these patients for 24 hours after any thyroid surgery. Okay? Unless it is done as a daycare procedure, this is the guideline that is given.
Yes.
So, as you said, everybody should be aware of how to release this hematoma by immediately removing the sutures and then evacuating the hematoma to release the compression, and at the same time take all measures to correct the hypoxemia that is associated with this condition. Okay, so that is the newer thing that may be asked in the examination because it is now very commonly practiced and included in the difficult airway society guidelines. So especially examiners coming from big institutions like AIMS or other areas, they are all practicing this as a routine in their institution, so they may ask you all these questions.
Okay.
So with that, I'll just go for a quick presentation.